Welcome to today's session, sponsored and put on by the East Texas Geriatric Education Center, addressing difficult topics in aging and disease. This is session 3 that will focus on everything you need to know about cancer. I would like to acknowledge our partnership with the East Texas Area Health Education Center East that have been really valuable in terms of our collaboration and distribution and connections with our consortium partners in East Texas. Okay. This is, as I said, the third session. It's in a series of 4 dealing with these difficult topics. And when you want to look at it, it is really about challenges to working with older patients and disease processes. And we will have our final session on the 3rd Wednesday in May 16th, looking at modeling long-term care that will focus on nursing home residents and older prisoners. And we hope you can make it then as well. This will be a very short introduction because we have a lot to do today and a lot to fit in 3 hours. And everything is in your handouts, so I'll just briefly go over this so we can get going here. You have your agenda here with our 5 speakers, and this will cover the whole gamut of cancer care with an overview of basically epidemiology of cancer given by Catherine Coaxley, then looking at screening with Dr. James Goodwin, treatment of cancer with Dr. Holly Holmes, a short break, and then to kind of go along with treatment, what about overtreatment or aggressive treatment? And this will be given by Dr. Gulshan Sharma. And finally, with Dr. Linda Elting, supportive care, not just for treatment for end-of-life care, but this new wonderful area of survival of cancer. Okay. And this will also be set up now as a webinar, and I will give you later on, those that are connecting as a webinar, the number to call in for questions and answers. Okay. The whole day has a list of learning objectives, which are listed here and in your handout. And we teleconference to our 5 of our consortium partners in Lamar, University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor University in Waco, Victoria College in Victoria, and Weatherford College in Decatur. Okay, there's lots of information available for CME. These are all free credits for doctors, nurse practitioners, and physician assistants. I need to disclose that all except Dr. Linda Elting have no commercial financial interests or affiliations to disclose. Dr. Elting discloses the following relevant financial relationship with Helsinn Pharmaceuticals in terms of having grant and research support. And the same for nursing with CNE, similar disclosures, and all the paperwork evaluation forms are in the back. Physical therapists, we have CEUs available as well as for occupational therapists. Okay. This is really about CERCIT, Comparative Effectiveness Research in Cancer Cancer in Texas, and all the speakers are affiliated with CERCIT. And you can find out more about this work being done, this collaborative work, which has been wonderful because we've been bringing in other researchers from MD Anderson, Rice University, University of Texas School of Public Health, and Baylor College of Medicine, and the Texas Cancer Registry.
That's quite a title. I should have shortened it. But I want to focus on geriatric assessment and multidisciplinary geriatric assessment and how that could guide more appropriate cancer treatment for older people with cancer. I didn't say elderly. I noticed that Dr. Goodwin pointed that out on his title slides. I'm going to talk to him about that and see what he thinks. The objectives are in your handout. The goal of geriatric assessment is to help provide information that adds to understanding a better balance between what I would consider ageism and overtreatment. That there is certainly a concern that we treat older people with cancer simply based on age alone, but that a lot of older people with cancer are overtreated for their cancer and then suffer the toxicities of cancer treatment. So we have to better determine where is that balance, and this is where geriatric assessment potentially comes in. Why is this even important? Older people are more susceptible to the toxicities from cancer treatment. They have reduced physiologic reserve, and I'll go over a little bit of that later. Reduced psychological reserve, reduced social reserve, predisposing them to toxicities in multiple different areas of their lives. And then it's possible that cancer behaves differently in older people. So one example would be acute myelogenous leukemia, or AML, which is probably more aggressive in the elderly compared to younger patients. So how would that change the treatment in an older person? But many cancers actually behave in a more indolent fashion. So beyond a certain age, maybe 75 or 80, possibly because of the cellular changes that happen with aging and the senescence or aging of those cells, they just don't promote a really good environment for cancer to grow. So cancers, for example, in older women might be, breast cancer in older women may be a more indolent disease and less aggressive and less likely to end an older woman's life compared to a younger woman. And Dr. Godwin mentioned that a little bit as well. And then, of course, other outcomes might be important to patients, and I'm going to highlight that a little bit. That for an 85-year-old person with cancer, maybe the same cancer that a 35-year-old person has, the goals are pretty different in terms of treatment. A younger person with cancer is very primarily focused on survival. An older person with cancer may be focused more on things like function, quality of life, the ability to continue to physically do what they're doing now. And then we really just don't have a lot of data for what we do in older people just across the board. And we talk about this in geriatrics all the time. If we only practiced evidence-based medicine, we would just never do anything. I mean, there are very few things that we might do. And when you look at cancer trials across the board, the enrollment of people in trials of cancer agents is completely different from the actual distribution, as Dr. Cooksley covered, of cancer, which is by and large a disease of aging. So I'm going to present a couple of clinic patients of mine that highlight how geriatric assessment helped or didn't help them make a decision that they were happy about. I guess that's foreshadowing things to come. So the first is a 78-year-old woman who had a breast cancer recurrence. She had had a left breast cancer many, many years ago, which had been treated with surgery, radiation, and chemotherapy. She was actually referred to me by one of our CERCIT co-investigators who's very geriatrically minded, because the patient said, well, I'm 78, I'm too old for treatment. I mean, why would I have any kind of cancer treatment at all? So even though she stood to potentially benefit from treatment, she did not want it. That being said, she actually had already had surgery. What she was debating was whether to have chemotherapy and hormonal therapy. So this is for her right breast cancer recurrence, which is many years later. And then another patient was a 73-year-old man who was diagnosed with pancreatic cancer. These are not the patients, obviously. These are, representative pictures that I'm showing you. But this guy, the picture I show you really highlights the issue here. To the surgeon's credit, he just looked older than his age, and they didn't like that. Like, this guy doesn't look 73. Why doesn't he look 73? Maybe a geriatrician can help me figure that out. So that's really why he was referred to me. Figure out why this guy looks older than he really is. And the other red flag that they knew about as well was before he was even diagnosed with his pancreatic cancer, his daughter had moved in with him when his wife died. And that just seemed like a red flag, right? Like, why did his daughter move in? Just because. So they wanted to know what's going on. They were considering doing a Whipple procedure, which, if you're familiar with a Whipple, it is a very extensive, difficult surgery. It requires a very prolonged recovery, has a lot of complications. The perioperative mortality rate at centers like MD Anderson is quite low, but the long-term benefit is pretty low as well. So I'm basing some of this on the current guidelines from the National Comprehensive Cancer Network. There is a panel that has given recommendations about senior adult oncology and how to approach cancer in general. Obviously, different cancers are different in older people. So question number one, is the patient in front of you likely to suffer from or to die from the cancer that they have? Is the cancer going to kill them or cause suffering? And then the balance of that would be, or is the patient in front of you likely to die from something else with their cancer? So that's the first question regarding these two patients. So to answer that, obviously we have to think about, well, how long is this person likely to live if they didn't have cancer, right? If they walked in the door without their cancer, what is the likely life expectancy? So the longer you live, because you've survived all the things that killed everybody that you know, right? So it shouldn't be surprising that a super fit 90-year-old woman has more than 6.8 years remaining life expectancy. Sorry, I knew I was going to do the Vanna White thing. I'm sorry. I could do the computer thing. I have a real problem with the staying put. So the super fit 90-year-old woman is likely to live more than 6.8 years. Should that be surprising to people in this room? No, but it is pretty surprising to an oncologist. But a very frail 75-year-old woman, so somebody with some bathing impairment, 2 or 3 very severe comorbid conditions, is likely to live less than 6.8 years. So this person is going to live less long than this person. So obviously numeric age alone cannot determine whether someone's going to suffer or die from their cancer or with their cancer. So in our case, we have a 78-year-old woman. I don't really know where she fits. This is the healthiest quarter, this is the frailest quarter, and these are the people in the middle. She's somewhere in between here, and she's somewhere in one of these 3 groups, right? So we have to figure that out, because the range here is all the way from less than 6.8 years to more than about 16 or 17 years. That's a pretty big difference. And then we've got this 73-year-old man who looks older than his age, and he theoretically fits somewhere between here, and we also don't know where he is on this spectrum. So this is just a simpler way to put it that I sometimes tell the hem-onc fellows who come to my clinic, because this is news to them. They don't get this really huge range in life expectancy. So just the average 65-year-old woman is likely to live to the age of 84. Just think about it that way. The average 85-year-old woman could live to the age of 92, just on average. Those are my fit people, not my average people. So some other ways to think about life expectancy and to determine whether somebody before they even had the cancer, what would their likely life expectancy have been? This is a study conducted in community-dwelling frail elders. So again, these are the people who have the least life expectancy, the group that's sort of in that less healthy quarter. And they put in all these potential predictors of life expectancy, and it turns out that being a man, you actually add up all the points, and based on the points of these bad factors, you figure out whether you're at the 0 to 3, 4 to 5, or more than 5 points, and just get the probability of dying in this number of years. So being a man gets you a couple points. Of course, already being older, that's going to increase your risk of dying sooner. Having dependencies in toileting, partial or full dependence in dressing, having cancer, and having other comorbidities, heart failure, COPD, renal insufficiency. And I'm sorry, but renal insufficiency gets you 3 points, but COPD only gets you 1. And then if you think about, we were thinking about, well, what about they're walking in the door with these conditions before we even know they have cancer? Well, what about we already know somebody has cancer? So does cancer trump comorbidity, comorbid illness, or does comorbid illness trump cancer? Well, in earlier stage illness, so if you look at life expectancy in men and in women, having no conditions as compared to 1 to 2 or more than 3 has a significant difference in your survival from that cancer. Once you have metastatic cancer, it really doesn't matter if you have comorbidity. The cancer is life-threatening, and that's what's going to end your life early. At earlier stages, it's important to know if someone's very healthy or has a lot of comorbid illness. So let's take our particular patient. This is actually what, I didn't do this at the time because I think I changed some of her details, but I did this for this talk. There is a wonderful resource available to all clinicians, Adjuvant Online. It is absolutely, it's absolutely great to help facilitate conversation with a patient who's unsure about treatment. So I just plugged in a 78-year-old woman, and I said she had average comorbidity. So then they call that the general health is fair. I gave her positive estrogen receptor status, meaning that she would potentially respond to hormonal breast cancer therapies. And I gave her a particular tumor size. I couldn't remember. I said she had no lymph nodes involved and that she was grade 3. I don't remember all these details. And then I considered a chemotherapy regimen that they recommended for me just to see what they would come up with. And this actually will spit out a document that is in your patient's language that you can also understand, otherwise it would be difficult for you too, that you can share with your patient and discuss the benefits and risks of therapy. So in the case of this woman, I have to say when she first showed up, I thought it was crazy that she was considering not having treatment because it was so obvious to me that she would benefit from treatment. But if you look at this, if she went for no additional treatment, and the green bar here is the people who are going to be alive in 10 years. I went ahead and looked at 10-year survival, but you can also make this look at 10-year recurrence, which is more important to some people. 45 out of the 100 women die from other causes. 10 out of 100 die because of cancer. So what I wanted to know at this point with her is what's in this blue box that might get her, or whether she's this person, and how to prevent her from being this person. So if she went just for hormonal therapy, that saves an additional 2 out of 100 women. Chemotherapy, an additional 1 out of 100 women. And combination therapy, an additional 3 out of 100 women. This is not exactly as helpful. There's no Adjuvant Online for pancreatic cancer. But when I think about the gentleman who's 73 who's referred to me for pancreatic cancer, who might have a Whipple, well, I just, SEER, the SEER website's a nice resource. You can just go in and plug all sorts of statistics that you'd like to look at. So just for comparison's sake, I'm showing you the 5-year survival for colon and rectal cancer up here, and then the 5-year survival between the years of 1975 and 2003 for pancreatic cancer. And this is not by treatment or no treatment. And believe me, the curve when you have a Whipple, it doesn't go like this. Oh, you have a Whipple, so now you're up here. No. This includes everybody who had a Whipple or didn't have a Whipple. So I already know that his 5-year likelihood of living because of the pancreatic cancer is in the single digits, percent-wise. Okay, so I'm armed with this rather grim information for my second patient, but uncertain information for my first patient. So then the next question, or maybe this is really the first question, right? What does the patient want? What's important to them? What are they hoping to get out of treatment? How do they feel in general about treatment, about medication, about surgery, about their goals for their lives? And then how do they feel about the cancer specifically? So what do they want out of this? And in the case of, in the case of Miss M with breast cancer, she had a great life. She didn't want to have treatment because she did not want to have any toxicities. And she actually had done an extensive amount of research. She came in with a legal pad completely covered front to back on at least 5 pages of all the potential therapies she was going to be offered, and she had made a column for pros and a column for cons. And she had weighed everything she could possibly find on the internet. It was amazing. I mean, I learned things, which, I mean, I usually do, but it was just really amazing. So, and her, her goal, again, she just did not want to have toxicity. And I'll get into this a little bit later, but one of the reasons she did not want to have toxicity is that she is the primary caregiver for her older sister who has dementia. If she can't care for her sister, nobody can, is the way she sees it. So when I talked to the gentleman with pancreatic cancer, well, what would he be hoping that surgery would offer for him? And he said, I really just don't think I want surgery because his main goal in life was to not have to go to a nursing home. And he was convinced that if he had surgery, he was going to end up in a nursing home. So the next question is there anything that the patient has that's likely to make cancer treatment difficult? And is there any cancer treatment we are considering that's likely to make an underlying condition worse? So what's the interaction of the chronic conditions on the cancer and the cancer on the chronic conditions? So I have to put this in every single talk I give. I love this slide. It just explains so much of the biology of aging and what we understand in geriatric medicine. So when you think about as a young person, you have all the reserve available to you. All your organ systems are working wonderfully. You have all your heart, kidney, lung, etc. reserve. And as you get older, as a wonderful feature of normal aging, you have diminished reserve across multiple organ systems. And so that as a younger person, any kind of insult, such as cytotoxic chemotherapy, can kind of bump you out of your normal homeostasis where you like to be, but you can get back pretty well because you have a pretty good range of reserve in which to exist. But as you get older, you don't have very much that you can accept before you're completely out of whack or before you have tendinitis. As I'm feeling my aging. And so the same follows for a biopsychosocial model, which is not just the biologic reserve, not just the organ reserve, but your psychological reserve and your social support system become more diminished with age. And so you really have diminished capacity to deal with a significant insult. And then if you look at cancer specifically and the potential impact of conditions common with aging, so geriatric syndromes like falls, incontinence, delirium, cognitive impairment, hearing loss, vision loss, and you look at disability, so physical dysfunction, and just comorbid illness, so other chronic diseases. There is quite a lot of overlap. So if you look at people with colorectal cancer and with breast cancer, there's a substantial chunk of people who have disability and comorbidity and geriatric syndromes. So these people are going to be quite vulnerable to toxicity. And then there are some people who only have comorbidity, who only have geriatric syndromes, who only have disability. So identifying these people who have some overlap here would be important to prevent them from having further decline. And cancer does increase the odds of becoming frail or becoming more vulnerable, according to standardized definitions of frailty and vulnerability. So people who have a history of cancer compared to people who don't have a higher odds of vulnerability, higher odds of limitation in bathing, dressing, eating, higher odds of limitation in driving, managing finances, taking medications, higher risk of geriatric syndromes, and I'll show that in a minute, higher odds of frailty, so weight loss, malnutrition, possibly cognitive impairment, disability, that whole spectrum. And also higher odds of rating themselves as having fair or poor health status. And cancer survivors compared to those who don't have a history of cancer have a higher risk of all of these geriatric syndromes: vision loss, hearing loss, eating problems, memory loss, incontinence, osteoporosis, depression, and falls. So if you just look at the number of these syndromes by cancer survivors in blue versus non-cancer, these are significantly different. So, of course, I wanted to determine in my patients whether they had conditions that were going to interact with their cancer and whether their cancer treatment was going to worsen their conditions. And Miss M only really had spinal stenosis with pretty significant back pain, which she was actually treating with acupuncture. I didn't even touch that with a 10-foot pole because it was working. And essential tremor, which also was somewhat improved with acupuncture. But the acupuncture was a really good clue to me. She really does not like to take medication. She takes nothing. She only takes ginseng, and she says it's because it helps her back. I don't know. She takes a lot of other herbal products. I did look at some of those to make sure those weren't going to interact with her cancer treatment. But really pretty healthy. And then Mr. V with pancreatic cancer. Lots of other medical problems. High blood pressure, coronary artery disease, had a prior heart attack, he had a stent placed, he took many, many regular medications. So that's all just comorbidity, right? I mean, those are all individual illnesses that each impact their likely life expectancy. So certain comorbidities may be more important than others, you know, so for example, I'm not entirely sure the impact of the spinal stenosis, although it is pretty important, but I certainly know that coronary artery disease is going to be a problem. And then the level of control of those comorbid conditions is pretty important. But other things actually impact outcome in older people who have cancer. So having poor cognition or a frank diagnosis of dementia, malnutrition, depression, having functional dependence, so difficulty eating, bathing, dressing, etc., or managing meds and finances. These factors have all been shown independently to predict outcome in certain populations of people with cancer. And physical function also is important, so gait speed or other measures of physical ability. So this is where we get to comprehensive geriatric assessment. The purpose of comprehensive geriatric assessment is to test multiple different domains that are all potentially associated with outcome in people who have cancer. Not necessarily cancer-specific outcome, but overall outcome. And it involves the use of standard, valid tools that are used to measure common geriatric problems in other settings. And the advantage is that you can diagnose a problem and potentially it's reversible and you could intervene and fix it. That's a very optimistic way of presenting it. But so there is no standard geriatric assessment that's used in oncology, but most include these domains with these kinds of tests. So to look at comorbid conditions, when we go back to Adjuvant Online, for example, Adjuvant Online does not really include a very sophisticated measure of comorbidity. It's just they have some, they have a lot, they have a little. It doesn't use the same kinds of criteria as these other indices. So the SIRS-G is a comorbidity index that rates the severity and number of specific comorbid illnesses that are probably important to outcome. The Charlson Comorbidity Index has been used a lot in cancer populations. There are some comorbidity indices that are used in specific tumor types or cancer types. So one example there would be people who are being considered for stem cell transplant, who have leukemia, for example. There's a specific index for stem cell transplant. And of course, number of medications or the kinds of medications that are used to treat those comorbid conditions, that is assessed in comorbidity. Cognitive function is important at baseline because it can be affected by cancer treatment as well. There are standard tests used. I'm not a big fan of the MMSE, but it is probably the one that has the most data in cancer. So I list a few of those there. And then depression, anxiety, so the geriatric depression scale, the hospitalized anxiety depression scale. Nutritional status with the mini nutrition index. Social support, there are some standard tools to measure that, including the medical outcomes survey. Functional status, so activities of daily living, instrumental activities of daily living, and performance status, although performance status does not consistently correlate with functional status. And then physical performance, so like the timed up and go or the short physical performance battery, which includes balance, gait, and strength. So this is just to give you a flavor of the kind of toolkit that somebody would have who's going to use a comprehensive geriatric assessment. And it's pretty time consuming. So given that that's sort of an overwhelming number of tests that probably takes somewhere between 30 to 60 minutes to complete, does every single older person who has cancer need a comprehensive geriatric assessment? I don't know. The former recommendation of the National Comprehensive Cancer Network was that everybody over the age of 70 would get a screening test called the Vulnerable Elders Survey. And this is a 13-item questionnaire. I'm just pointing out that it can fit on one page, not so that you could read it. But it really is quite simple. It can be done by clerical staff over the phone with the patient, and it gets at age, self-rated health, and some of the functional status measures. So that everybody who screened in as that being abnormal, which is a 3 or higher, would get a comprehensive assessment before their cancer treatment to determine whether the cancer treatment was appropriate for their level. And that if the comprehensive assessment was completely fine, then you would treat that 85-year-old like you would a 50-year-old. I doubt an 85-year-old would have a normal CGA, but You get what I mean. And that you would only just think about any comorbid conditions that might impact chemotherapy or surgery or etc. And if there was anything wrong on the CGA, you would then consider reducing the dose, reducing the number of chemotherapy drugs, or implementing some kind of intervention to try to reduce the likelihood of toxicity. And that if anybody came up and that screening questionnaire was totally fine, then the oncologist would screen them for normal gait, cognition, and for any geriatric syndromes. I have to say that the oncologists really struggle with this because they don't routinely ask about falls or, you know, cognitive impairment or delirium or hearing loss, incontinence. But that is the recommendation, that they look for those things. And then if that looks okay, then the person's fine and keep going. If any of these things come up abnormal, then the person goes for geriatric assessment. And then of course anybody who shows up to clinic very obviously frail, very functionally impaired, having difficulty with ambulation, has multiple severe comorbidities, that you really focus mostly on relieving symptom burden. So I did a comprehensive assessment on my patient with breast cancer, keeping in mind that she did not want to take medication and that she thought she was old, basically. Obviously, I already found that she had minimal comorbidity. The spinal stenosis probably important to her long-term function, but unclear how important to everything else. All of her screens were completely fine. Her physical performance was perfect. She didn't have any functional dependence, but the thing is, she does have this essential tremor. I mean, even though she had the tremor, she did completely fine on physical performance measures. So that was a little bit of a concern because she was considering chemotherapy that would cause neuropathy, and it was not clear to me whether it would worsen her tremor. And again, as I said, she's the primary caregiver for her sister, so that had to be a big consideration. And when I looked at Mr. V, he had more than 3 severe chronic diseases that were sort of under modest control, but his mini-mental, which I was using at the time, I now use a different test, the Montreal Cognitive Assessment. His mini-mental was 18, which was really surprising to me. I mean, he really was not somebody that really struck me as somebody with moderate dementia. He was not depressed. He was at moderate risk on his nutrition screen, and that probably was a function of his cancer. His physical function and his functional status were normal. My test of his physical function was fine. He reported his functional status was normal, but his daughter was there in the background. You know that thing when the daughter's in the background going like that the whole time? When you're saying, so do you manage your bills? Yes, of course I do. So, of course, he did have excellent social support. His daughter had moved in with him. She had decided to retire early, and so she was just there for him. I told Miss M, I really don't know. This is an area of great uncertainty. I mean, I can't say, I think without breast cancer, you'd definitely be around in 10 years or more, 20 years. Therefore, you might consider treatment. But, she was still very hesitant, but she ultimately went along with treatment. And she went the whole shebang, which caused her tremor to be much, much worse. And it really did get to the point when she was having the highest amount of toxicity that she really had to hire someone to kind of help her sister with bathing and dressing occasionally. So that was unfortunate. She was pretty unhappy about that. And unfortunately, that experience really predisposed her to really dislike hormonal therapy. And she's now on Arimidex, but she just takes these long Arimidex holidays because she will not accept any side effects. Which is unfortunate because if anything from Adjuvant Online, the Arimidex is probably the thing that's going to most likely benefit her. And that, take it or leave it, I probably would have left the chemotherapy behind and just stuck with the hormonal cancer therapy. She's okay, but it was rough there. And she won't accept any medication to improve her symptoms of neuropathy or tremor, which is unfortunate. Not that there's a lot that would help her. And Mr. V, the guy with pancreatic cancer, very unfortunately, he decided that instead of having surgery, he would go with single agent chemotherapy with gemcitabine. which also really has very little potential to benefit him. But the thought at the time was maybe if the tumor responded, it would be so obvious that he should have surgery. But even then, he was still unsure about it. He decided to go for a dose of gemcitabine, and I recommended that he not. He ended up in the hospital with dehydration, and he actually had to have a stint in skilled nursing to recover from the dehydration from one dose of chemotherapy. That was enough for him. Like a little short stay in SNF, that was it. No more of that, because he saw what life in a nursing home would be like, and as he said, that was his main goal in life, was to not be in a nursing home before he died. So he ultimately chose hospice care, and he died 11 months later, which is probably similar to what his life expectancy would have been had he had a Whipple. So I'll just kind of try to briefly wrap up where CGA is going. How is geriatric assessment helping people determine the best cancer care? And I think this varies in different settings and centers, and it's very different in Europe. In France and Italy, geriatric assessment is just well ingrained into the culture of deciding what kind of treatment is better for an older person. The biggest debate there right now is whether an older person is 70 or 75, and that's sort of, you know, creating some heated debate. But there is no debate about whether we should include this multidisciplinary assessment as part of the consideration of doing full therapy versus reduced therapy. So just a few little examples here. So CGA has been used to predict toxicity, and for frail versus non-frail patients that were categorized based on this sort of multidimensional assessment, there was 3 times the odds of having severe toxicity in people who were 70 and older who had surgery for colorectal cancer. So the severe toxicity was more like severe perioperative complications. And that was in Norway. Another use of it would be to determine the treatment that should be offered. So again, this is really happening a lot more in Italy and in France, where this multidimensional assessment, so in one example, of 161 patients who had various different cancers, 82% of those patients had CGA results that actually affected the ultimate treatment that was offered. So they either delayed the therapy until the patient was more healthy, or they actually offered less intense therapy. And then another example is just to risk stratify the people. So when somebody comes in for treatment, you can just say, look, I think we could offer this treatment, but you have X% chance of having toxicity from it. And that is shown here and in the next slide. So if you just look at the survival, both 5-year, which is in blue, and 10-year, which is in maroon, for 660 women who were 65 and older and they had early stage breast cancer, they did an adapted geriatric assessment that, you know, looked at these different domains, and they looked at how many deficits they had. So having 0 deficits, they had an 82% 5-year survival, a 58% 10-year survival. But if you look down, you can just see really nicely that the more deficits you have on geriatric assessment, the more diminished your survival is at 5 and at 10 years. So it's pretty important to know ahead of time. So if you find somebody who has, you know, functional impairment, physical impairment, severe comorbidity, and nutritional loss, that this is the person you might say, hey, look, you know, let's see if we can fix these things first, because this doesn't look so good. And again, like Dr. Goodwin, I wouldn't go into the room with this chart in front of me, but I would frame it a certain way. So the oncologists are starting to do this and to realize that they need a brief tool to help them figure this out too. That it's not realistic that every person 70 and older is going to see a geriatrician. So what do they need to know to figure out who's going to have the most toxicity? So they did a comprehensive geriatric assessment, and they, in about 500 people, various different cancers, mostly solid tumors. And these are all the things that ended up being significantly predictive of toxicity. So it's kind of an interesting bag of things. Being 72 or older, having an abdominal or pelvic cancer, so GI or GU, getting standard chemotherapy, getting more than one chemotherapy, being anemic, having kidney dysfunction. Now that's all just the normal stuff they already knew about, right? Well, having hearing loss, having falls, having trouble taking your medications without help, having trouble walking a block, and having decreased social activity because of your health. All of these things are predictive, and they weighted them with a scoring system. And if you look over here, that if you add up the total risk score here, these are the people who had low risk of grade 3 to 5 toxicity from chemotherapy, medium risk, high risk. And the oncologist will say, well, my rating of performance status is just as good as geriatric assessment. Why don't I just do that because it's quicker? But actually, their rating did not predict who had the most toxicity. So this is hopefully going to change some of that initial screening that happens by the oncologist, because those are pretty brief. So long term, the ultimate goal is a completely shared model of care, and that in the ideal setting, the patient would be diagnosed. Well, let's not talk about whether they'd be screened for their cancer from Dr. Gubin's talk, but once they are diagnosed with cancer and they're referred to an oncologist, there's this equal portion of primary geriatric care and oncologic care that helps to determine the most appropriate treatment for a patient. And yes, once they go into that treatment path, no doubt, especially in my patients, they sort of get lost to you. They're off in chemo land, and you see them out the other side. So the ideal would be that you still have this little relationship with them somewhere, so you can check in periodically and make sure they're making it through okay. So this is sort of the ideal model that's a shared care model, and that, you know, long term for survivorship, of course, the primary geriatric person is really responsible for all of that care in the long term. So it's crucial that we really know what's going on here and that we're part of that decision as well. Thank you very much. And I think that with the newer agents like aromatase inhibitors, the unfortunate thing is that what I'm seeing most is that women are faced with, do I have joint symptoms, joint pain, muscle pain, which can be very significant in older people who already have arthritis. That's actually why my patient went off of her aromatase inhibitor, was just the daily symptoms. Now, aromatase inhibitors, to my knowledge, do not have a big impact on stroke risk, but they do have plenty of other significant side effects that turn people away from them, for sure. I think that's going to be an interesting question. Yeah, so what do oncologists accept as acceptable risk before they would give certain treatment? I think this is not quite ready for prime time. Now it is going to be validated prospectively. I mean, this was a development cohort. It is a very large multi-center study. It was very, I'm sure, difficult and expensive to do. However, in the US, we don't really use geriatric assessment to determine treatment yet, and we haven't determined whether that is an effective way of determining cancer treatment. Now, in Europe, they've just already kind of gone ahead and done it, you know, regardless of the validation of this kind of approach. So this article actually just came out in the late fall, early winter 2011. So it remains to be seen how it will impact. Oh, I'm sorry, I don't have the reference there. It remains to be seen how it will impact the oncologist practice, because this is pretty simple to do. And if you know that somebody is in your 77 or 89% risk, you might want to bring down the risk just by reducing the number of chemotherapy drugs. But then is that balance of potentially decreased activity against the cancer worth it? Yeah, so this is their Karnofsky performance scale. We use ECOG at MD Anderson, and they'll usually offer standard treatment to somebody with a performance status of 0 or 1. So that kind of equates to a Karnofsky about, you know, 80 or higher. So there are definitely people who have a performance status of 2 or worse. So the higher the performance status from ECOG, the worse you are. That might benefit from more palliative kinds of approaches that include chemotherapy, but then again, there are also people who have a true performance status that's worse than assessed by the physician because they don't do ADLs and IADLs, and those people end up getting standard care and have more toxicity. That's the fear. So that some combination of factors that's really represented over there, that's a nice smattering of age, cancer factors, treatment factors, biologic factors, and then geriatric factors, that putting those all together is more predictive than just whether somebody could walk into your office or not. I use one that I now discovered might be patented, and I need to reconsider that. But that's actually why I don't use the mini-mental state exam, by the way, the MMSC, because it's patented, and they do crack down on infringement of patent use. But I do use the CATS I can't remember if CATS is the ADLs or IADLs, and then I use the, I can't remember the name of the IADL person, but I use the 8-point IADLs. I use the, so, you know, I use a scale that allows full independence, partial dependence, and complete dependence. And so then I grade that 0, 1, 2. Thank you very much.